Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about hyperparathyroidism, a disease that causes high blood calcium that can lead to serious health problems and sometimes even death. The good news is that in most patients it is curable, and here to tell us how that happens is tonight's guest, endocrine surgeon Adwoa Opoku-Boateng. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. That's 866-3200. And questions by email, too. There's our at WLAE.com, and we'll have that number and that email address on the bottom of our screen when we get to that portion of our program. Well, Dr. Boateng, or Dr. O as she refers to herself and her patients call her, attended Loma Linda University School and residency right here in New Orleans at Ochsner. She completed a fellowship in endocrine surgery through a combined program involving the Medical College of Wisconsin, Duke University, and the University of Wisconsin in Madison. Dr. Boateng is a fellow of the American College of Surgeons, a member of the Southeastern Surgical Congress, the American Medical Association, and the Association of Endocrine Surgeons, and she is board certified in surgery. And it is our pleasure to welcome Dr. Adwoa Opoku-Boateng to Hello Health. Good to have you with us, Doctor.
Thanks so
for
much
coming.
for having me.
Yeah, and you've been here before. It was a couple of years now, and some changes in your personal life since then, right?
Yes, I was fortunate enough to get married last year, and then in the last couple of months I've run my second half marathon, which was a good accomplishment for me, I think.
And how are both going?
Everything is fantastic.
All right. And you said you ran a half marathon.
Yeah.
Any goals of moving up?
Not right now. I would like to run another half marathon, maybe improve on my time a little bit. Maybe down the line we'll look at doing a marathon.
Yeah, well, good for you and congratulations.
Thank you.
On the marriage. Well, tonight we are focusing on the parathyroid and hyperparathyroidism, but just for informational purposes, remind us the difference between the thyroid and what it does and the parathyroids.
Sure. So the thyroid gland is a butterfly-shaped organ that sits at the front of the neck and helps regulate the rate at which your body functions. So it affects most of your organ systems in a rate-controlled fashion. So it can affect metabolism, temperature, heart rate, energy level, all those organ systems can be affected, which is separate from the parathyroid gland, and they are typically 4 glands that sit on the back surface and help regulate calcium specifically.
And again, parathyroid meaning next to thyroid, so
Yes.
it's right there.
Yeah.
And when you say small, you mean small, right? Like the size of grains of rice.
Absolutely, very, very small. the size of a grain of rice, 40 to 50 milligrams, very, very tiny, hard to pick out probably even to the naked eye.
Most people have 4, but not everybody.
Correct. The majority of people have 4 glands, but very rarely you can get a 5th or a 6th gland called a supernumerary gland. It doesn't mean that you are more likely to necessarily be hypercalcemic or have high calcium levels, but it can just be an anatomic variant.
All 4 do the same thing?
Yes.
Do we need all 4? Why did God give us 4 of them?
I mean, ideally you would use all 4 from research and knowing that we can remove 3 glands, you can still function normally. So I guess to the strictest criteria, you only need 1 gland, but they all work together, work in concert. So if one is not functioning, the others can kick back in and work for you.
Okay. You told us all the things the thyroid does. What about the parathyroid? When it's functioning properly, what is it helping with?
Sure. So at a cellular level, every single cell in your body needs calcium. And so the parathyroid gland helps bring the amount of calcium into your bloodstream that's needed. It's under very tight regulation. If you don't have enough calcium in your bloodstream, those glands release a hormone called parathyroid hormone. And that hormone works on the different organs in your body to help increase the blood level of calcium. It works on the bones to put more calcium from the bones into the bloodstream. It works at the intestinal level and helps you absorb more calcium from your diet with the help of vitamin D into the bloodstream. And then it also works at the kidney level to help you reabsorb more calcium from the kidneys into the bloodstream. It's almost like a thermostat is how I like to think of it.
And you brought along an image which shows us what you're talking about.
Absolutely. So just to clarify again, when you don't have enough calcium, those glands release the hormone, and it works at the bone level. It works on a cell called osteoclast that helps chew up the bone, take that calcium where the majority of it is stored in the bone to put it into the bloodstream. Then it works at the kidney level with the help of vitamin D to help you reabsorb calcium to put that into the bloodstream. And then also it works at the intestinal level, also under the influence of some vitamin D to help you absorb it from your diet. And then once you have enough calcium, that thermostat turns back down and less of that hormone is released. It's under tight regulation. That hormone, the half-life of it is only 4 to 5 minutes, so it's constantly changing and constantly being tweaked based on what your needs are on a minute-to-minute basis.
So what we're talking about tonight is hyperparathyroidism. So by definition, what is that?
So hyperparathyroidism is when your body is releasing or producing too much parathyroid hormone. So, but sometimes you can get a growth on one or more of the glands, and when that happens, it can continue to release the hormone into the bloodstream. I like to say it goes rogue. It does its own thing. You have enough calcium in your bloodstream, but it says, I don't care, I do what I want. And it continues to dump the hormone into the bloodstream. So it continues to be in that same cycle on that first slide that we saw. So you continue to have calcium taken out of the bones to put in the bloodstream, continue to be reabsorbed at the kidney level, and then it continues to be absorbed at the intestinal level. And left unchecked, it can cause some problems down the line.
About 200,000 people a year in the U.S. Develop this condition. Do we know what causes it?
There is a very small subset of the population that it can be associated with a genetic mutation, but the majority of people who end up with this, it's just their own body or one of the glands forms a little growth or a tumor within that gland that causes it to go rogue,
And can be caused by another disease in some cases?
Another
disease in the body, some other dysfunction? Could that cause hyperparathyroidism?
So there's a medication in like lithium that can cause that to be a problem. If you're exposed to radiation, that can cause changes in there. And then also there's a term of secondary hyperparathyroidism, which is a little bit different than primary, where folks who have kidney failure can actually down the line end up with hyperparathyroidism as well.
Okay, and let's look at, you brought along some statistics too, to talk about these patients. So occurs approximately, what is it that occurs in 80 to 85% of the time?
So this is in terms of primary hyperparathyroidism, which is by far the most common, people who have normal kidney function, who have the growth on the gland. And so if I took 100 people who had sporadic primary hyperparathyroidism, 80 to 85% of them would have one gland that's affected. About 10% would have 2 or 3 of the glands that would have growths or be affected, and the last 10% would have all 4 of their glands affected by this disorder.
Okay, we talked about how dangerous it can be, but when the parathyroid is out of whack, why is that dangerous?
There are some end organ damage that can happen if it's left unchecked. If you, from a bone standpoint, if you remember, you're continuing to take the calcium out of the bones. The calcium in the bones is what makes the bones strong. So if you continue to leach calcium out of the bones, you can get bone weakening, and you can hear terms such as osteopenia or osteoporosis, which is weakening of the bones. And so the long-term effect of that is to potentially put you at risk for fractures or have you have fragile or brittle bones. At the intestinal level, you can have problems such as constipation and abdominal pain because of all of the calcium that's there. At the kidney level, you can get some calcification of the arteries, and you can actually end up with kidney dysfunction, kidney failure. You can end up with kidney stones as well. There's some other anecdotal evidence that shows that people can have problems with their heart. If they're already prone to have calcifications in the heart, it can actually accelerate the rate of the calcification, and so you can end up with some end organ damage in the heart in the long term as well. And then there are also these neuropsych findings that sometimes people can have. They can be a little bit hard to pinpoint directly to hypercalcemia because there can be a number of reasons that you can have some of these symptoms, but we know that there's a direct correlation. So some of those findings would be insomnia, trouble falling asleep or trouble staying asleep. It can be problems with concentration. People will describe it as a mental fog. They have kind of a problem. They can't quite concentrate the way that they normally would be able to. They can have mood changes. Maybe they might not say that they're more irritable, but people around them might say that they're a little more irritable than they used to be. So all of those things can happen as a result of leaving high calcium levels unchecked and untreated.
You talked about some of these earlier, but who's at risk of developing hyperparathyroidism?
So we know that women are probably almost 3 times more likely to be affected than men.
And we know why.
I don't know why. We don't know why. There doesn't appear to be a hormone effect, progesterone or estrogen or anything along those lines. But when you look at all comers, we do know that women are more affected. If there is a family history of hyperparathyroidism, so if you had a mom or your dad or your sisters were affected by this disorder, you are more likely to be affected by it. We touched on this earlier. Lithium use is a medication that in long term, it's a psych drug that's used for different
psychiatric illness treatment.
Yeah, absolutely. That down the line can cause some problems as well. And then a history of head or neck radiation. Radiation to the area at a cellular level can cause a change and cause some problems with the parathyroid glands and hyperparathyroidism as well.
How is it diagnosed?
So it's actually a blood test. Most frequently for people who are asymptomatic, people will go for their regular checkups on a yearly basis, and they're getting routine blood work. So you're getting a basic metabolic panel or a metabolic panel provided by your primary care physician. You get a calcium level that will be seen on there, and sometimes they can track over the years, and you can see where someone started to get higher calcium levels, higher than normal. And this, when it gets to a certain point, this will likely trigger a workup process to go down that road to determine if there's anything else that needs to be done. If it's persistently elevated, the first thing the doctor will likely do is to look at your medications. Because besides the lithium, there's a class of drugs called thiazides, which is a medication that's commonly found and given to patients with high blood pressure. That's actually a medication that can increase your calcium level. So the doctor will look at your calcium levels and also look at your medication to see is that potentially a cause. If you're on that medication, the doctor may, for a short term, stop that medication to see if your calcium level will normalize. The other thing that they'll do is they'll recheck it. Was it just a one-time level, or is it persistently elevated? And if it is persistently elevated, then they will likely check a parathyroid hormone level. And often they won't check them in isolation. They'll check them at the same time because, like we talked about before, the half-life is 4 to 5 minutes. It's constantly changing. So you want to see them in relation to each other at the same time. There are other tests that you'll see that they'll order. One might be a phosphate level. And the reason they would check a phosphate level is because at the kidney level, like we talked about earlier on, you're reabsorbing that calcium at the kidney level, and it's a calcium phosphate channel. So as you're reabsorbing the calcium, you're losing phosphate. So patients with this disorder will often have a low normal or a low phosphate level. So that's something that might be looked at. The other thing that they'll check is a vitamin D level. Vitamin D is used, the active form of vitamin D is used to help you absorb calcium at the intestinal level. So if you're vitamin D deficient or you don't have enough vitamin D, your sources of calcium have to come from other places. So the parathyroid may have to work overtime and continue to release at a higher level in order to maintain your calcium level. So you always want to know what the vitamin D level is doing, because that can be a source of having hyperparathyroidism as well. They will also likely check urine calcium levels for two reasons. One, they'll want to look and see, are you spilling, are you losing a lot of calcium into the urine? The other reason is there is a rare genetic disorder that can happen at the kidney level. And if that happens, you will have a higher calcium level but a low urine calcium level. And so you want to rule that out, because if you have that disorder, which is called FHH, or familial hypercalcemic hypocalciuria, if you have that, surgery is not the answer for you. So you want to make sure we rule that out as the source of why you're having high calcium levels. And they'll check your kidney function, because again, we talked about unchecked long-term high calcium levels can cause decrease in kidney function down the line. So they'll want to know what your kidney function is doing at that point in time, and are you seeing any end organ damage or any long-term effects from having high calcium. And then a bone density test. And the reason they're looking at the bone density test, like we talked about before, is the majority of your calcium is stored in the bones. Unchecked, continued leaching of calcium from the bones can cause decrease in your bone density or the bone strength. And so they'll want to look and see, are we seeing some effects of that? Again, with hyperparathyroidism, we will particularly see that at the hip level and also the wrist. The bone density doesn't typically check the wrist, but that is something that we'll add on if we're particularly concerned or looking at from a hyperparathyroidism standpoint.
So for parathyroids in most patients, do these tend to all go bad at the same time?
So usually that is not the case. Again, like we talked about, the majority of people, 80 to 85% of them will only have one gland that causes a problem. And so if you can identify that one gland and remove that one gland, then you've cured the patient. The other 20% of the time, you'll see that there are more than one gland that's involved. And so a majority of time, it's one gland for sporadic primary hyperparathyroidism.
So the electrician or the auto mechanic hooks it up to the lead and says, okay, this works or this doesn't. How do you determine if it's out of whack, and which one is out of whack?
Yeah, so first, again, it's a diagnosis of blood tests and urine tests. It's not a diagnosis where we're going to send you for x-rays and tests to see which one it is. First, we diagnose you with that disorder. Once we diagnose you with the disorder, we say, do you meet criteria for surgery? Every person that has hyperparathyroidism doesn't necessarily need surgery immediately. There are certain criteria that we look at to determine who would be the best candidates for surgery. We look at, do we see some of that end organ damage? So if you've had a history of kidney stones, then you probably are a good candidate. If you're already showing effects of bone loss, especially at the hip and the wrist, then we're saying we should consider that. If you're spilling a lot of calcium into the urine, those are people that we're looking at. If you have very high calcium levels, the normal calcium level is going to be usually anywhere from, depending on the lab, 10.2 to 10.5. So if you have calcium levels as high as 12, you're going to be a good candidate for surgery. If your calcium levels are even as high as 11.5 and don't reach all the way 12, then you're also a good candidate. So there are certain criteria that we look at. The neuropsych symptoms that we talk about, that problems with memory and mood and energy level, fatigue is also another one I failed to mention before, that can be a big problem. Those are a little bit harder to say, you have these problems, we need to operate on you. But some of those other ones, once we know you have it and when you meet criteria, then we go on that process. The imaging studies are just to help direct the surgery. If you don't meet criteria for surgery, or it's decided that you're not a good candidate for surgery, it's very unlikely that you would get those localization studies.
But again, how would you know which of the four is out of whack?
So there are a number of localization studies that you can do. One is called a sestamibi scan, which is a nuclear medicine study, because there is increased turnover in mitochondria within the parathyroid gland. It will actually light up. They they give you an injection, take pictures early on and bring you back a couple hours later. It should have all washed out. If we see something bright image on there, then that tells us that's the one that's abnormal. There's another test that you can do, which is an ultrasound. It's the same test that you would get to look at your thyroid, but in the good hands of a excellent ultrasonographer, you can often see enlarged parathyroid glands from that standpoint as well. There's another test that can be done, which is a CT scan. That's becoming a little bit more common, that you're seeing a 4D CT where they take thinner sections through the neck. It's a timing of the injection where you can, again, also see that abnormal gland that lights up. Rarely, sometimes in redo surgery, you'll hear about people getting MRIs of the neck as well to look at it. But those are the 4 main tests that help localize or help figure out which of the glands are abnormal.
And you would want all that information before surgery, or is that happening at the same time?
Usually it's going to be before surgery. You may not get all of those tests, but it just depends. So kind of sequentially you'll get the test in leading up to surgery.
Okay, so if someone is diagnosed with the disease, what are the treatment options?
So unfortunately, there's not a medication that can cure you of this. There is a medication specifically for secondary hyperparathyroidism that can be used to treat it, but there's no cure in terms of medication for this problem. Surgery is the only way to cure you of this. So determining which of the gland is abnormal and removing them is your treatment option. Now, if you are diagnosed with the disorder, but we say you are not a good candidate for surgery at this time, the doctor will likely continue to monitor you with serial calcium levels, parathyroid hormone levels, and potentially checking to make sure that the kidneys and the bones and the rest are still doing okay.
All right, and we'll talk about that more in just a moment. Our guest tonight is Dr. Adwoa Opoku-Boateng. Tonight we're talking about hyperparathyroidism. Before we get to the surgical options, we're going to talk about the surgery in a moment. I want to invite our viewers to call in with your stories and your questions. Our number is 504-866-3200. That's 504-866-3200. And we have an email address too. You can send us questions that way. And there it is, hhquestions@wlae.com. So let's talk about the option of surgery and the different kinds of surgery, because there really are 4 or 5 different ones to treat the disease, right?
Absolutely. So there are a number of different types of parathyroid surgery. Historically and still commonly performed is what we call a bilateral exploration. So what that entails is opening the neck and looking at all of the parathyroid glands, potentially biopsying all of the glands to determine at a microscopic level which of them look abnormal or have abnormal tissue and abnormal cells, and then removing the 1 or more glands that are abnormal. So that's one that's often performed. Then there's what's called a focused parathyroidectomy. And there are a couple ways that you can do that. One of the ways is, and this really ties into that imaging on the front end. If you've had an ultrasound, let's say in a sestamibi scan or a sestamibi scan and a CT scan that both say, you know what, we see something on the left side, it looks like the left lower side. Based on that imaging, we will focus our dissection directly to that area. And when we do that, we use something, some type of adjunct, such as intraoperative PTH monitoring. And what that is using the knowledge that that half-life of that hormone is only 4 to 5 minutes. If we've pulled out the right gland, we should see your numbers drop within 10 minutes into the normal range.
And you're monitoring all that during surgery?
We can actually check blood levels and check those things and look at that during the time of surgery. And if your numbers don't drop by that 50%, don't drop into the normal range, that clues us that you may be in that 20% that has more than 1. And so we would continue the exploration from that standpoint. So you can do a focused exploration that focuses on using that preoperative imaging, what you know to be abnormal based on the imaging before you went to the operating room. Then there's the radio-guided parathyroidectomy, and that uses nuclear medicine injection. Again, using that same idea that those parathyroid glands, because of the increased turnover, it's going to suck up that nuclear medicine or that tracer. We can actually use a probe similar to what they do when they use sentinel lymph node imaging for breast or sentinel biopsies for lymph nodes. You can actually use that probe and see where the hot spot is in the neck, and then focus your dissection there, take out the offending gland, see the measurement, and then you look at the background, because if that's the only one, the numbers from that tracer, and the probe should drop down significantly. If not, there's a potential that there's a second area of abnormality that's going on. And then there's the video-assisted parathyroidectomy. And that, there are two separate ways that you can do it. You can do one where you make an incision sort of low in the neck and use the video camera, make small incisions and use a video scope and actually go in and find the gland that way. Sometimes they'll place incisions behind the neck to try and hide the scar and tunnel towards the area of the gland in question and remove it that way. So, you know, if you look online, you look on the internet, you're going to see so many different ways, and every different spot will probably tell you this is the best way to do it, this is the only way to do it. And I tend to disagree with that, and I think most research would disagree with that. I think all of these are very good ways to do it. The most important thing is to find someone who does parathyroid surgery and does it routinely and does it well, and they are going to use what they are comfortable with and what their facility has and what their facility has success with. So there may be a group in one group part of the country that does focused dissection and uses the gamma probe or uses that radio-guided parathyroidectomy and has fantastic success. But if there's a group in another part of the country that doesn't have that success, but they do a great job using the intraoperative PTH levels and your levels of cure are the same, that's what's going to be most important. What the surgeon is comfortable with, finding someone who has good success with it, and making sure that you have that conversation with your doctor and your surgeon.
And in theory, all four get you to the same place, which
Correct.
is well.
Yeah, so looking at the studies, whether it's a bilateral exploration or a focused parathyroidectomy, when done properly, the cure rates are going to be the same, which is going to be about 97%. So even in the best hands, the cure rate's probably going to be about 97 to 98%. So even if you find that one, there is anywhere from 1 to 3% chance, closer probably to 1 to 2% chance that you could get what we call recurrent hyperparathyroidism, or you could have a second gland that becomes abnormal down the line.
All right. So folks at home are wondering, okay, it's one the surgeon's most comfortable with.
Yeah.
So which one are you most comfortable with and why? And then I'm going to ask you to walk us through one of these surgeries.
Sure. So looking at that list, there are a number that I am comfortable with. The one that I do most frequently would be the focused parathyroidectomy, but that is only for patients who localize on the front end. So if you don't localize, that is not a reason to not have surgery. If we've determined that you have hyperparathyroidism and that you are a good candidate for surgery, and we've taken you through 3 or 4 different tests, and we can't find the one, that doesn't mean you're not a good candidate for surgery. That just means we need to do the bilateral exploration, which is the conventional way where we make an incision and look at all of the glands and then assess at that point which of them is abnormal. So we do that routinely for folks who don't localize, and then also for folks who have the genetic mutation, like what's called MEN, is a genetic disorder that affects all of the glands. We will do the 4-gland or a bilateral exploration. And then the focused parathyroidectomy for the people who, on more than one imaging study, say they have congruent or corresponding answers, say the left lower one is the one that's causing the problem. We can very reliably go in with a very small incision. I make it low in the neck so that if you were to wear a shirt or a dress like I'm wearing, hopefully you wouldn't be able to see it. Go in directly to that parathyroid in question, remove
Small
it.
How large is
It's going to be just about an inch,
Okay.
an inch or maybe a little bit smaller for the focused, minimally invasive. And then going directly to that, removing that, and then using the intraoperative PTH levels. We have a pretty good, quick turnaround time with that, and we've had good success with that. And so I'm comfortable doing that. But again, that's not for everybody. If you don't localize on the front end, if it doesn't seem like we can figure out which one, that focused dissection is not really going to be the one that you're going to be a good candidate for if you've got this problem.
Okay. And you said you would never take all 4, right?
Correct.
Even if all 4 were out of whack.
Yeah, so typically, even if all 4, or you've got what we call 4-gland hyperplasia, or all 4 glands are abnormal, what we'll want to do is what's called a subtotal parathyroidectomy or a 3.5-gland parathyroidectomy. We would want to leave you the size of 1 normal gland, because we know if we leave you the size of 1 normal gland, the size of a grain of rice, or 40 to 50 milligrams, your body should be able to function normally without requiring any calcium or vitamin D supplementation. So even in the cases where someone has all four, we would do a subtotal or a 3.5 gland parathyroidectomy. And often patients do fine, and there's no issues from that standpoint as well. There are some other little technical parts to it about potentially reimplanting it, because you can actually reimplant a parathyroid into the muscle. It'll grow a new blood supply and the cells will start functioning again. So there are some folks who will do that or employ that in case it were to recur. It would be an easier place to go back and get to in the future. But typically doing a total parathyroidectomy or removing all four glands is not what's done. It's a subtotal or a 3.5 gland parathyroidectomy that's performed.
All right, so surgery is a good option for a lot of patients,
Yeah.
but in some cases not. So you said monitoring, it's all going to start with monitoring for the patients who aren't good candidates for surgery.
Correct. So again, monitoring with calcium and parathyroid hormone levels, and then clinic visits to assess, are they starting to have symptoms? Are they having worsening symptoms? Typically, if you're having symptoms, you're going to be a candidate for surgery, but there are times that people for other health reasons are not strong enough or are not good candidates for us to put them on the operating room table and for them to undergo the stress of surgery. But typically, if you're not, we're just going to continue to follow, continue to monitor. If we're trying to get you healthy enough to get to the point of surgery, there are times that folks will potentially put you on a medication. There's a medication called cinacalcet, which can decrease the blood calcium level. It's not one that's used in the long term from a primary hyperparathyroid standpoint, but there are times it is used as a bridge. It's routinely used in secondary hyperparathyroidism, which is usually in the renal failure population. It's routinely used in that. But the physiology between primary and secondary is different.
All right. You know, my mom asked me, what is hyperparathyroidism? I said, watch tonight, you'll get all the answers.
So now you know.
And well, I knew going in, but only because I studied, and I know my mom knows now because you have been a terrific guest here in the first half. Your questions coming next. A lot of people on the phones already. Here's our phone number, 504-866-3200. That's 866-3200. Email questions too. We've received a couple of them as well. But back with your questions in a moment. This is Hello Health on WLAE.
I love taking care of my mom. It wasn't easy at first. She learned how to better communicate her needs.
And you learned how to not ignore yours.
I discovered how to make healthier meals.
And I discovered how much I enjoyed them.
Becoming a caregiver is a learning experience for everyone. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving.
And welcome back to Hello Health here on WLAE. Tonight we're talking about hyperparathyroidism, a disease that causes high blood calcium, can lead to serious health problems, and sometimes even death. The good news is, as we mentioned at the beginning, most patients are curable. Tonight's guest is endocrine surgeon Adwoa Opoku-Boateng, or Dr. O, and now we go to your questions. Let's start with Linda, who has our first question of the evening. Linda is calling us from New Orleans. Linda, welcome. You're on Hello Health.
Hi, Tom. How are you?
Great.
Dr. O, how are you today?
Good. How are you? Thanks for the call.
Oh, I love the show. But I am a patient of Oxner, and I was seeing Dr. Burchell before he retired, and he's been following me for hyperparathyroidism, that big word. And what my calcium level is doing, it bounces. I noticed that a value is like 10.5. Mine's have gotten over 10.5, but lately it's the highest now is like 10.1, so it actually went down. It's been as low as 9.8 and as high as 10.7 back in September of 2016. But I just had it taken again this month, and it was 10.1. Is it anything that I should really be concerned about?
That's a great question. So because the half-life is so short and because so much calcium is being used all the time, your values are going to change back and forth. Probably Dr. Burchell told you at some point that you have what probably is termed as mild hyperparathyroidism, where you actually probably do have it, but it's either normal calcemic or very mild hyperparathyroidism. So continuing to, if you're not showing the end organ problem, so again, besides checking the labs, I'm pretty sure that when you see the endocrine folks, the medical endocrinologists, they're also routinely getting bone density tests to make sure that you're not showing any signs of that, making sure that your kidney function is okay, making sure that you're not getting kidney stones, making sure that you're not showing some of those other signs and other problems that can happen. As long as you're not showing those signs, and the medical endocrinologists feel that it's safe to continue to follow you, I think that is something that you can continue to do. I think not following is not a good thing. You can't just say it was 10.1, I'm never going to check it again. But making sure that every 6 months to a year, they're checking those levels and they're monitoring to show and see if there are any signs that it's getting more persistent or getting worse that would make them say, okay, now is the time that we need to say that we need to consider surgery and look at that a little more closely.
Bone density test, would that be something else you would recommend?
Yeah, absolutely. So every 2 years, they're probably going to be checking that bone density test, and knowing the endocrine folks, they're very good at making sure that not only are they checking the hip and the spine, which is routinely done on a bone density test, but also checking the wrist, because very frequently we will see that even if the hip and spine are not affected, the wrist is affected. And that may be one of those things that shows up first and that may pull the trigger for them to send you on and say that it's time for you to consider surgery.
All right. Linda, thank you so much for your question and for your nice comments about the doctor and the program. Good to have you with us tonight. Let's go to line 2. Don is calling us next from Metairie. Don, welcome. You're on with Dr. Boateng.
Hello, Tom and Dr. O. I would like to thank you all very, very much for a very interesting program. I have been producing stones for over 50 years, and years ago I was on a combination high blood pressure medicine that had hydrochlorothiazide, and I stopped taking it, and then years later my new doctor put me on hydrochlorothiazide, and after the first dose I had to stop because that medication causes me very, very severe anal pain. But I'm getting sidetracked. Before I was put on that, in between, I was diagnosed with parathyroid adenoma, and I decided surgery was recommended. I decided against that because I went through all the studies, the sonograms, the nuclear scans, and they found nothing except the symptoms. And then later, I asked my doctor about vitamin D level, which he ordered, and it was 15, half of the normal range. And since I've supplemented vitamin D, I have not had any more kidney stones, and my doctor has not indicated anything abnormal with my blood work and all. So I thank you all very much. Dr. O, especially thank you for pointing the thiazide problem out to me, and I think that may be one of the root problems that I had. And I just wanted to make those comments. I really don't have a question, but I really appreciate your show.
Don, thank you very much. So vitamin D can be helpful, and obviously was to Don, right?
Absolutely. And so increasing that vitamin D level into the normal range at the very least. At times, there's some research that shows you can actually decrease the set point of the parathyroid hormone and potentially decrease your parathyroid hormone levels. If you have recurrent kidney stones and maybe something to consider potentially looking into surgery or looking and reevaluating again to see how severe the calcium and the parathyroid hormone levels are if you're continuing to have kidney stones.
All right. Don, thank you for the question. Again, the nice comments, and we're happy to hear that your condition has improved. Again, our phone number is 504-866-3200. That's 866-3200. We're also accepting email questions at this address, hhquestions@wlae.com. We do have a couple of phone lines open, and we've gotten a couple of emails. So here's the first one, Doctor. If I had thyroid cancer, does this put me at a greater risk of developing hyperparathyroidism?
That's a very good question. Not necessarily. The one risk factor that we know that is associated with both thyroid cancer and with hyperparathyroidism is a history of head or neck radiation. So if as a child you underwent head or neck radiation for some type of malignancy, or if you were in a place where you were exposed to environmental radiation, that the radiation risk will definitely increase your risk for hyperparathyroidism. But thyroid cancer in and of itself does not predispose you to hyperparathyroidism unless you had potentially medullary thyroid cancer and it was associated with a multiple endocrine neoplasia, or what we call MEN syndrome. In that case, there's a potential where there could be a link between the two. But again, that's a very specific and small subset of the population.
And you mentioned thyroid cancer. Is it possible to develop parathyroid cancer?
It is possible, but it's very rare. It's less than one in a million. It's very, very rare, but it actually is a possibility. Usually you'll see that the parathyroid hormone levels are going to be much higher than the sporadic hyperparathyroidism levels, and the calcium levels are often going to be very high as well. So if you see very high calcium levels, very, very high parathyroid hormone levels, it's something to consider, but it's much less common than hyperparathyroidism that is not associated with the cancer.
And if you're just joining us, the major risk factors, tough to call this a risk factor, being a woman, but 3 out of 4 cases, right, involve women?
So yeah, up to three times as many women can be affected by hyperparathyroidism, yes.
Okay, and family history.
Absolutely.
Okay, 2 greatest risk factors. Okay, doctor, here's another email question. We do have phone lines open, by the way, at 866-3200. Here's another email question. Does hyperparathyroidism lead to or cause osteoporosis?
Absolutely it can. So if I don't know if you were watching earlier in the show, but you saw that slide that talks about how the parathyroid hormone works normally. So normally it works by working on what we call osteoclast, which is a type of cell in the bone, and it will cause that bone to release the calcium. And unchecked, the long-term effects are continued bone loss, which will lead to osteopenia, osteoporosis, make your bones weaker, and 100% set you up for fractures, as well as bone pain and other issues associated with that.
Okay. Again, 504-866-3200 is our number, 504-866-3200, or send us questions by email at hhquestions@wlae.com, like this person did. Here we go, doctor. Is there any correlation between diabetes and hyperparathyroidism? Seems like the common symptoms are very similar.
So that's a very interesting question. There's not a direct correlation. We do know that also the long-term effects sometimes can cause problems with reflux, can cause problems with the pancreas in terms of pancreatitis from unchecked calcium or very high calcium levels. Usually not directly associated with diabetes, but if you have chronic pancreatitis, the long-term effects of that could lead to diabetes. But the diet type of diabetes and the islet cells that usually are associated with it, there's not a direct correlation, but there can be some sequelae down the line that can be associated. I don't know if that really if that completely answers the question.
All right. Thank you very much for the question. We appreciate it. Again, 504-866-3200. That's 866-3200. In the case where everything would have to be removed or the parathyroids are not working at all, you mentioned, because if you had nothing, you'd have to be on medication for the rest of your life. What are those types of medication, and exactly what does the medication do?
So typically you would have to be on calcium because your body would not be able to regulate calcium, so you would have to take calcium by mouth. And then you would also have to take vitamin D because your body would not be able to as well regulate the calcium and vitamin D. So we know that vitamin D helps you absorb calcium at the intestinal level, so that's one of the things. There's also a medication that is a parathyroid hormone analog that is now an injection that can be taken. And that actually simulates parathyroid hormone so that your calcium and vitamin D requirements potentially could come down. And so that is a medication in patients who are permanently hypoparathyroid, or either they've had all of their parathyroid tissue removed or none of their parathyroid tissue is functioning. In those cases, there's a medication or an injection that you can take daily that simulates parathyroid hormone.
Okay. No such thing as a parathyroid transplant, is there?
Not exactly. So I think I mentioned this previously. The parathyroid has the amazing ability to kind of regain function. So if, for instance, a parathyroid surgery or a thyroid surgery is happening and one of the parathyroid glands is removed with the thyroid, if you see it, you can actually mince it up into pieces and put it in a pocket of muscle, and it'll grow a new blood supply and it will start to function again. So you can do an auto transplantation where you can take your own tissue and put it back in there. It's rare that they'll use someone else's parathyroid tissue and give it to you, but it is a possibility. The other time is if you do a total parathyroidectomy and remove all of the parathyroid tissue, and then you leave one small little piece and, again, put it back into the muscle, it will grow a new blood supply. That can take some time. It can take 2 to 3 months for it to truly grow a new blood supply, but that can happen and it can start functioning again. So then you can potentially have new parathyroid tissue that's functioning.
Fascinating. Our phone number again, 504-866-3200. Let's go back to our phone lines. Calling us from Laplace this evening is Janie. Janie, you're on with Dr. O. Good to have you with us.
Yes, I'd like to ask the doctor this question. For years now, I've been having high blood, like 10.7, 10.5, 10.7. And I went through the nuclear test about 3 years ago, and it came up negative. It didn't show anything. And, of course, my diabetic doctor left, and I have a new doctor that I'll see next week at Ochsner. And I was just wondering, do you have any symptoms? Should I have any symptoms about it? I take 50,000 vitamin D on the 1st of every month, and I take 2,000 every day for my vitamin D. What can you tell me? What can I do?
That's a very good question. Thanks so much for calling in. There is not necessarily anything that you can do to prevent this. There's nothing that you did to cause it, and it's not necessarily anything that you would have in the way of symptoms. There are a number of people who will have symptoms, but there is a well-known subset of the population that has asymptomatic primary hyperparathyroidism. So looking at the blood levels, we know that your calcium level is elevated, and we look at it in relation to the parathyroid hormone, and they're both elevated, and we know it's not working properly. But despite that, you don't have those same symptoms that we'll talk about. You sleep just fine. You don't have any problems with insomnia. You're not having any problems with memory or mood. Energy level is fine. You don't have kidney stones. You don't have bone loss, you don't have kidney problems. You don't have kidney failure. You don't have the abdominal pain. All of those things are the typical symptoms that you would find. But even though you have it seen in the blood, that doesn't necessarily mean that you have to have those symptoms. So it's something that they would continue to monitor. And again, it's a diagnosis of from a biochemical standpoint, used with blood work and urine tests. So if you have it, just because you don't localize on a nuclear medicine study doesn't mean that you're not a good candidate for surgery. There are certain criteria that we look for to determine whether or not you're a good candidate for surgery. Age is going to be one of them, whether or not you've had kidney stones. Are you showing signs of kidney dysfunction? Are you showing signs in the bones where it's a problem? And then sometimes those neuropsych symptoms, those are going to be those indications. Also looking at whether or not you're spilling calcium into the urine. So if you meet criteria for surgery, even if you have a bone, not a bone scan, excuse me, even if you have that nuclear medicine or that sestamib or parathyroid scan that is negative, there are other tests they can do. They can also do an ultrasound. They can do a 4D or a parathyroid CT scan to potentially look for an abnormal parathyroid. And even if all of those tests are negative, if you truly have hyperparathyroidism and you meet criteria for surgery, you can undergo surgery and you can still be a good candidate for surgery even if you don't localize. You would just be that person that would need what we would term that bilateral exploration, where we would look at all of the parathyroid glands, potentially using that radio-guided parathyroidectomy where you can get the tracer before the surgery, and that can help us at the time of surgery. But even if they don't do that, just the 4-gland exploration where you physically look at them and potentially biopsy them if needed to look at them at a microscopic level to see if they're abnormal would be more than reasonable. So the first step is it sounds like you actually do have it. It's determining whether or not you truly meet the criteria for surgery, and working with your primary care doctor and working with your endocrinologist will be very important, because they usually will know all of those criteria, and when they say you meet criteria for surgery, they will send you on to the right place to make sure that you get that taken care of.
Thank you very much, Janie. We appreciate your call this evening. With any surgery, there are risks associated
Absolutely.
with it. But talk to me about the risk of this surgery and the recovery time.
So the risk of surgery, anytime you're surgery, there's always a risk of bleeding. The risk of bleeding is very low. It's less than 0.25%. Very, very low risk of bleeding. And bleeding in that it's significant enough, requiring a take back to surgery to take care of it. The risk of infection is very low, even also less than 0.25%. There are other risks inherent to it. The other thing that you'll hear about that are here talked about is the risk of recurrent laryngeal nerve problem. There are nerves that run on each side that give you your voice and the sound and the pitch of your voice. The risk of having a permanent problem, that is going to be about 1%, usually a little bit less than 1%. There can be some temporary problems with that, but the risk of a permanent problem is going to be low as well. Typically, the recovery time is going to be 1 to 2 weeks, and it's not 1 to 2 weeks where you're in the bed, you can't move, you can't do anything. Often you find that just because you've had surgery and you're recovering from surgery, that your energy level won't be as good. So most people have a little bit of pain for the first 3 or 4 days. They'll take a little bit of stronger pain medicine maybe for the first couple of days, and then are able to transition to extra strength Tylenol. Most people are driving within 3 or 4 days after the surgery, because you're able to turn, you're able to look in the blind spots, you're not on the heavy pain medicine, so you're able to be a good and safe defensive driver. I tell every patient, if you're taking the heavy pain medicine, don't get behind the wheel and drive, because I won't go to court for you. So you got to be smart about it. But most people are able to drive very quickly. The night of surgery, probably about 98% of people are drinking liquids, and 85 to 90% of people are eating solid food. So it's not like you're going to be on a soft diet and you're just on clear liquids. It's pretty well tolerated. The sore throat is almost like when you're sick and it hurts to swallow. But again, people are still able to swallow, they're able to eat, it doesn't last too long. The bounce back is pretty good. Usually within a week or two, people are feeling pretty good. And even within a week, the number of people who work desk jobs and aren't doing manual labor are able to be back at work and functioning without any trouble.
And if all goes well, normal function of the parathyroid returns
usually
quickly.
Yeah, usually within the first week or two. Typically, everybody doesn't do that. I know a number of people do this, and the way I was trained is that we will always put people on calcium supplementation after parathyroid surgery, because especially if you just have one parathyroid that is abnormal, the other 3 are functioning in that normal cycle, so they are sensing that high calcium level and they're asleep. So once you remove that, there's this transition period where they're waking up. So to prevent them from their calcium levels dropping too low, we will supplement them and put them on calcium. And it's not a prescription, it's Tums. It's calcium carbonate, anything you can get over the counter. And we just temporarily put them on that, and those other parathyroid glands will kick in, and able to be function, and we're able to wean you back off that calcium
Got a
relatively
couple more
quickly.
emails we're going to get
Sure.
in just about a minute or two left, so we'll go quickly here, Doctor. Is there any correlation between hyperparathyroidism and Hashimoto's thyroiditis?
So Hashimoto's thyroiditis is an autoimmune disease or chronic lymphocytic thyroiditis where your body attacks the thyroid. Typically with what we've been talking about tonight is sporadic hyperparathyroidism. And so there's not a huge correlation between the two because it's not your own body attacking the parathyroid glands. It's actually a growth within the parathyroid gland that's causing the abnormality.
Okay. Here's another one. I've heard lots of people are getting tested for thyroid issues. Is hyperthyroidism something that an overweight person having trouble losing weight should be checked for?
So typically, if I understood the question correctly, they asked about hyperthyroidism and overweight. So typically, hyperthyroidism is going to be one related to the thyroid, not to the parathyroid. And it's about overactivity or overproduction of thyroid hormone and too much thyroid hormone being released into the body. And the typical symptoms are going to be the heart rate beating really fast, actually weight loss. Sometimes you can have a little bit of weight gain because you have an increased appetite. You're hot when everybody else is cold. You can have some diarrhea. So the weight gain is often going to be associated with underactive or hypothyroidism. Now, hypercalcemia or hyperparathyroidism there's not usually a direct link to obesity. Sometimes there can be a problem because too much calcium in the blood. One of the side effects can be fatigue or lethargy or decreased energy level. So if you have a hard time having the energy that you should have, it can be hard to get out and exercise. And if it's hard to get out and exercise, the calories in, calories out ratio is off. And so then you can have problems losing weight from that standpoint. Again, typically when you're getting your basic labs, the calcium level will be checked. And so when they're checking a calcium level, if the calcium level is normal, that they usually are not going to go on and check a number of other tests unless there's a suspicion for hypercalcemia or hyperparathyroidism.
And I think that's what this last email refers to. Doctor, here it is. Should you request a certain blood test annually during your wellness visit to detect this problem? And it does show up, right, in a typical panel.
Absolutely. That's a fantastic question. So typically, when you're getting your lipid profile done, you're also getting a metabolic profile done. And in that metabolic profile, you will often see a calcium level if they're checking a complete metabolic profile. So that you will get that calcium and a phosphorus level that will be checked, and they will be able to screen for the hypercalcemia from that standpoint.
All right. I want to thank the doctor for her information tonight and obviously for her work in the Oxnard Health System. Thank you so much. It's been a fascinating program.
Thanks so much for
You're
having
welcome
me.
back anytime. All right. To make an appointment with any Oxnard physician, including tonight's guest, or to register for any of Oxnard's Hello Health seminars, you can call Oxnard at a number set up just for viewers of this program. In fact, I ran into somebody yesterday who said they called, got an appointment within 2 days, and they were very happy about that. So 842-5669. That's 842-5669. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com. Oxnard's got a lot of them too on its website at oxnard.org. Our thanks again to tonight's guest. Thanks to Humana and Oxnard for making our program possible. A special hello to Diana. Diana, we are an important part of this program. We're thinking about you tonight, all of us here. And final thanks to you for your support of our program, Hello Health, and our station, WLAE. Good night.
Hello Health on LAE is presented by the Oxnard Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxnard Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxnard, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.